This is Professor Kaiser with Chapter 50 from Iggy, Concepts of Care for Patients with Stomach Disorders. Right. So first thing, we're going to do a little patho review for gastritis. Gastritis is essentially the inflammation of the gastric mucosa or that gastric lining, and it occurs because of results of irritants or cellular changes. There are a couple of different kinds or ways that it is classified. So erosive gastritis is when ulcers develop from hydrochloric acid injury to small vessels. That leads to edema and bleeding that causes the ulcers. Prostaglandins also provide a protective mucosal barrier that prevents the stomach from digesting itself. And when patients ingest NSAIDs at a frequent rate, that inhibits the prostaglandin production, which increases the risk for gastritis. Chronic gastritis is inflammation that is more spread across the stomach lining and causes atrophy of the lining. With chronic gastritis, there is a decrease in acid secreting cells that causes a decrease in absorption of vitamin B12. Remember, we talked about vitamin B12 and decreased absorption of that leads to pernicious anemia. And then there's also H. pylori infection that we'll talk a lot about throughout this chapter that causes the release of inflammatory cytokines that damage the gastric mucosa. There are some other causes of gastric or chronic gastritis, which include alcohol use, radiation therapy, smoking, and surgeries that involve the pyloric sphincter, which can cause reflux of alkaline secretions into the stomach. So, looking at gastritis in the nursing process, first method or step that we want to educate our patients on is prevention. So through education, we can promote prevention of gastritis by encouraging a well-balanced diet with minimal caffeine. That actually includes minimal decaf, and of course, decreased or minimal intake of alcohol. Patients who are traveling should be sure that water and food that they're eating is safe without the risk of contamination. And then, of course, exercise and stress management also decrease the risk of gastritis through decreased stress. Assessment for patients with gastritis includes symptoms of epigastric pain, and this can be described as heartburn or dyspepsia. If patients report blood or emesis of blood, vomiting blood, or dark sticky stools, so bleeding within that GI tract. And then gastritis from food poisoning can cause nausea and vomiting that has a very quick onset. Assessment also, of course, includes the EGD. It's the most useful diagnostic tool for gastritis. Typically, a biopsy is also taken to determine the cause or type of gastritis. So we're looking at that risk for H. pylori infection. For patients with chronic gastritis, symptoms are often vague and usually only present as upper abdominal discomfort or epigastric pain after they eat. However, with chronic gastritis, patients might also develop anorexia or decreased appetite. Interventions for gastritis vary depending on the cause. So patients with acute gastritis will have improvement when the cause is resolved. We encourage them to eliminate irritating foods, follow a bland, non-spicy diet, eating more frequent small meals or snacks. And then patients that have bleeding with their gastritis might require a blood transfusion. So managing that bleeding. We can treat with medications, which include proton pump inhibitors, such as omeprazole, or histamine 2 receptor antagonists like famotidine. Patients might also use antacids for symptom relief, And you can see a table on page 1097 to review some of those. All right, so now we're going to move on to peptic ulcer disease. So reviewing that pathophysiology, there are 3 types of ulcers that can occur when the GI mucosa are not able to protect the epithelium from acid and pepsin. H. pylori is the cause of many peptic ulcers. So there are duodenal ulcers. They're the most common of the 3, and you can look at that picture to reference the area. These ulcers occur with pH levels, and when the pH levels in the duodenum remain low or more acidic for long periods of time. Hypersecretion from protein-rich meals and vagus nerve excitation and rapid emptying of food from the stomach increase the acidity within the duodenum. Gastric ulcers develop in the antrum or lower portion of the stomach near acid-secreting mucosa. If the pyloric sphincter is not functioning appropriately, bile can reflux back into the stomach, causing inflammation, and delay of gastric emptying occurs, which worsens the injury with that ulcer. Lastly, there are stress ulcers that occur when patients are hospitalized for medical illnesses, such as sepsis or head injuries. They're more common with those types of patients. Or patients who are NPO for surgeries may also develop gastritis, which can lead to ulcers. To prevent this, most of the time we're going to see that our patients are admitted with IV PPIs or proton pump inhibitors. And complications related to patients with stress ulcers are primarily going to be bleeding from the stress ulcers. If you look at the table 50.2 on page 1100, that will give you some differentiating characteristics of the gastric and duodenal ulcers. Okay, so with peptic ulcer disease, there are complications related to the ulcers. First one is hemorrhage. That's the most severe complication. Often this is caused by gastric ulcers. Patients will present with vomit that is bright red or coffee ground in appearance. This occurs because of the digestion of the blood from gastric acid. Other signs and symptoms of gastric bleeding include decreased hemoglobin and hematocrit, decreased blood pressure, tachycardia, weak peripheral pulses, dizziness or lightheadedness, and confusion in the elderly population. If patients have small bleeds from gastric ulcers, they are noted with dark, sticky, or tarry stools. Perforation can occur when the ulcers become deep and the thickness of the stomach is worn away. This allows the stomach contents to leak into the peritoneal cavity. For these patients, it will present as sudden sharp pain in the mid-epigastric area, and then it spreads across the abdomen. Patients will often develop peritonitis related to this or inflammation of that peritoneal cavity. They'll present with a rigid abdomen. They prefer to lay in a fetal position to decrease that muscle tension. These patients can quickly become septic and go into hypovolemic shock, so they do require immediate surgery. Pyloric obstruction can occur due to scarring, edema, or inflammation. These patients will typically present with abdominal bloating, nausea, and vomiting, and it can lead to metabolic alkalosis and/or hypokalemia. Intractable disease often occurs when patients have multiple stressors or they do not adhere to treatment of peptic ulcer disease well. With intractability, the patients continue to have recurrent pain despite treatment. So your assessment for patients with peptic ulcer disease. First, we're going to take that history. We're going to review for a history of H. pylori infection. We're going to talk about their over-the-counter drugs, including NSAIDs. if they've ever had any gastric surgeries or radiation treatment, and then if there's been a recent change to their pain, worsening, increasing in frequency or duration or location. And then physical assessments with that pain, they typically will present with tenderness and pain in the midline area between the xiphoid process and umbilicus. Patients with perforation will have intense pain with that rigid abdomen and rebound tenderness. And that's again from that inflammation of the peritoneal cavity. Other physical assessments will be assessing for dyspepsia, which can be described as a sharp burning pain, or sometimes patients will say they have fullness, pressure, or feel hungry related to dyspepsia. We're also going to monitor these patients for hypovolemia just to assess with the increased risk of bleeding, a bleeding ulcer. So we will monitor for orthostatic hypotension, assess for dizziness, or signs and symptoms of dehydration. Psychosocial needs, assess for lifestyle changes related to symptoms. And we also want to assess our patient's ability to adhere to treatments to prevent further complications from arising if they are being treated. And then lab, there are several tests that can be done to assess for H. pylori. There's the breath, blood, or stool assessments. Typically, the breath or stool assessments are the most indicative, but a serum blood study can also assess for H. pylori. Hemoglobin and hematocrit will be assessed to rule out or assess for bleeding. Also, you can do a occult blood test to assess for blood in the stool. For diagnostic assessments, the EGD is the most accurate assessment. It allows for visualization of the ulcers, and then also it allows for biopsy of that area to be taken to further assess for risk factors such as H. pylori. Also, there are nuclear scans to assess for bleeding. Patients are injected with contrast and they're able to use the nuclear imaging to assess if there is a bleeding ulcer present. So our treatments for our patients with peptic ulcer disease, we can treat with drug therapy. And that, of course, will just be pain relief initially. And then with H. pylori patients, treatment usually involves triple medication therapy, where they're treated with a PPI and 2 antibiotics, typically metronidazole or flagyl, and then either amoxicillin or tetracycline. And some providers will even treat with a 4th drug, bismuth subsalicate can be added, which prevents the H. pylori from binding to the mucosal lining. Although I butchered that word, that subsalicylate is also part of aspirin. So patients who are on this medication need to be assessed for aspirin so that they are not taking too much of the subsalates. They can also be prescribed hyposecretory drugs, such as your PPIs and H2 receptor antagonists, and those just help to reduce the gastric secretions. And then PPIs are also preferred for treatment of peptic ulcer disease because of their delayed release after passing through the stomach. So for those patients who have peptic ulcers present lower in the GI system, the PPIs are a little bit more effective in helping with treatment of symptoms related to that. However, we have to remember with our PPIs, long-term use increases the risk of osteoporosis, so patients need to be assessed for long-term use and if they need to continue. And then also with long-term use or use of omeprazole, it does inhibit some functioning of clopidogrel or Plavix. So if a patient is on clopidogrel, then another PPI might need to be used. Patients who are taking PPIs should be instructed to avoid abrupt discontinuance. For nutrition therapy, it's typically used for symptom relief. So patients are encouraged to have bland diets or to avoid irritating foods. But it's been found that this doesn't necessarily help as treatment, but more so for symptom relief. And then also avoiding alcohol and tobacco. Finally, complementary health approaches, stress relief, and then some herbs and supplements can be used. It is thought that the ulcers, as we discussed before, can be caused by stress. And so your book talks about using yoga or other complementary health approaches to decrease levels of stress to prevent ulcer development or progression. Now, one of the big complications related, as we mentioned before, is the GI bleed. So the book does touch a little bit on an upper GI bleed and what nursing cares need to be considered, and then also measures to prevent or to fix hemorrhaging. So, as I mentioned, active bleeding is considered an emergency. So we need to also look at supportive measures for these patients to prevent them from going into hypovolemic shock. We're going to monitor their INOs. We're going to monitor vital signs, electrolytes, and then also initiate volume replacement therapy. Typically, they use the isotonic solution or 9.9% sodium chloride, normal saline. We're going to monitor their hemoglobin and hematocrit. If their hemoglobin and hematocrit drops significantly, they might require blood replacement. Or if they have an elevated PT or prothrombin time, they might require fresh frozen plasma to help bring down that clotting time so that we can decrease the bleeding and get the bleed under control for that patient. Non-surgical interventions, NG tube placement is used for multiple different reasons. It can be put in for assessment of the presence of blood and the rate of bleeding into the stomach. It also helps to empty blood in from the stomach to prevent dilation of the stomach. Not used as often anymore, but they used to do lavage through the NG tube or rinsing of the stomach to assess for active bleeding. So they would instill a warm solution, either sterile water or sterile saline. You could also use tap water. It's just facility protocol, but they would flush that into the NG tube and then pull it out and put more in and continue to do this until the saline or solution came out clear. The other thing with NG tube placement, it can also be used for decompression when there is pyloric obstruction from edema or spasms. And then endoscopic therapies would typically be done with an EGD when the patient's having that upper scope done. Those include embolization of arteries while performing the EGD. They can embolize those arteries or stop a bleed through many different means with endoscopic therapy. They can either inject chemical, or they can use heat or lasers to stop bleeding, or mechanical methods such as a clip. And then interventional radiologic procedures are completed when the endoscopic procedures are unsuccessful, or if a patient has a significant bleed and is not a candidate for surgical interventions. So with IR procedures, they're typically done through either the femoral or brachial access, and through the vessel, they are able to enter and treat the bleed with injected medications right at the site. Finally, drug therapy, they would use aggressive acid suppressive agents to allow clots to stabilize. So once a clot has been formed, to prevent that clot from moving or rebleeding from occurring, they need to eliminate or decrease significantly the amount of acid secretion. And that usually involves multiple medications, including H2 receptor antagonists and PPIs. Patients with upper GI bleed might also have to have a surgery. Usually they're less common now because of the other methods of treatment that are available. But if they do have surgical interventions, they prefer minimally invasive procedures or laparoscopic procedures because it decreases the risk of complications such as infection, bleeding, and pain, and then also allows that patient to return home sooner. Surgical procedures that can be done might remove chronic ulcers, or they can control bleeding if it's not able to be done from one of the other methods previously described. And then there are some surgeries to help decrease acid secretion, which is a subtotal gastrectomy, removes a portion of the stomach. Pyloroplasty opens the pylorus, or vagus nerve cutting is the vagotomy to control secretion release. All right, now we will do gastric cancer. So a patho review of this. One thing to note is atrophic gastritis is a precancerous condition, but oftentimes things that can cause the atrophic gastritis can lead that patient to eventually have gastric cancer. With the atrophic gastritis, patients have an alkaline environment in the stomach, which allows bacteria to multiply, and that causes the gastric mucosa to change, which increases their susceptibility to the gastric cancers. H. pylori, of course, is the biggest risk factor with infections. And then also patients who have diets high in pickled foods, nitrates, and overly salted food can develop atrophic gastritis. And diets low in fruit and vegetables can also increase that risk. Let me go back to the adenocarcinomas are the most common type of cancers that develop in the mucosal lining. And typically there is metastasis seen with gastric cancer, either spread through the lymph tissue in close relation to other GI organs, or systemic spread is often seen to the lungs and the bones. Going back to the risk factors, I do have that listed there. Males are more common to have gastric cancer than female, and patients greater than 50 years in age. There are other risk factors that include history of gastric surgeries, which increases the risk of that atrophic gastritis. Patients with pernicious anemia and gastric polyps are also more at risk for gastric cancers. Okay, assessment of these patients. Typically, patients with gastric cancer are initially asymptomatic, which does make it more difficult when it comes time to treat. When they are diagnosed, the disease has usually progressed, and we see some of that metastasis that was discussed on the previous slide. If they do present with symptoms, initial symptoms include dyspepsia or abdominal discomfort. And then eventually we'll see different anemias related to poor absorption of iron and vitamin B12. The best method for diagnosing gastric cancer is that EGD with a biopsy. And then because of the risk of metastasis, CT, PET scans, or MRIs are also done to assess further progression of the cancer. For interventions with these patients, it depends on the stage the cancer is when it's diagnosed. If it's diagnosed early enough, some patients can receive radiation and chemotherapy. However, radiation is used in moderation because of the proximity of the stomach to other organs that are more sensitive to radiation, such as the liver. And then these patients might qualify for surgical interventions. Again, this depends on the progression of the cancer. If it's caught early enough, resection to remove the portion of the stomach with the cancer, it can be done, but oftentimes it's not caught soon enough. So then these patients are typically having a removal. And these are more palliative measures, or measures for the patient to be comfortable, because if it's already progressed into the lymph tissues, then results from the surgery are not going to be beneficial except for comfort measures. So considering the different surgeries that these patients can have, they can have partial resection of that stomach, or they can have a total removal of the stomach. And oftentimes, if that is done, then they're going to have this anastomosis, or that where they connect the esophagus to the jejunum. And you can see in the image there. With post-operative considerations for these patients, we of course want to consider all of the risk factors that occur with most surgeries, including atelectasis. So we're going to do our pulmonary hygiene for those patients: turn, cough, deep breathe, incentive spirometer. Monitor their bowel for return of function very closely. Sometimes they do have to have the NG tube in place for an extended period of time to allow that incision to heal. So the bowel needs to be monitored through frequent assessments of bowel sounds. And then also risk for infection either at the surgical site or internally. And we've reviewed infection signs and symptoms frequently. We talked previously about peritonitis, which can occur if there's leakage at that site where there's connection between the esophagus and the jejunum. Any leaking into the peritoneal cavity can cause the symptoms of peritonitis. Also, if there's any type of blockage from edema that occurs, there can be acute gastric dilation, which can also occur if an NG tube is in place but is blocked. And so frequent assessment for these patients of that NG tube for patency is necessary. We also need to consider these patients for what's referred to as dumping syndrome. And that is when the patient has had that entire stomach removed and there's a fast shift from food and liquid into the small intestine, which can cause abdominal distension. Usually about 30 minutes after eating is when this will present, and patients will have symptoms that include vertigo, tachycardia, syncope, sweating, pallor, and palpitations. There is also late dumping syndrome that can occur about 90 minutes to 3 hours later. This occurs when there's excessive level of insulin release that allows those high carbohydrate foods to quickly move into the jejunum. Symptoms are similar for that as well. Dumping syndrome is typically monitored with nutrition changes. And if you look at the box 50.3 on page 1107, you can see the different dietary adjustments that might need to be made for these patients. Delayed gastric emptying can also occur. Usually this happens within the first week of surgery related to swelling around that incisional site or the connective site. And typically it will resolve within a week, but usually this is prevented with that NG tube placement. And then, of course, after we eliminate that stomach, it does have that responsibility we discussed earlier this semester with absorption. So patients will have some vitamin deficiencies, including vitamin B12, calcium, and vitamin D. These can lead to problems such as pernicious anemia or anemia related to folic acid and iron deficiency. So these patients might need to be administered long-term vitamin B12 injections or supplemental replacement through folic acid and iron. Typically not going to be oral, again, because of their inability to absorb appropriately. That is all for that short chapter.